I had a couple of staff members.
I'm recording it, and now
Perfect.
all I have to do is figure out where it's gonna let me let in the attendees.
I don't see Andrew on the list.
There he is. I see him.
Ah, there we go.
See, I just sent him the link. Yes.
I had to log into Steve's account on the browser and then join. So it was a whole thing.
Okay. I think we may actually be live with the attendees because I don't think he gave us a practice component on it. But if the attendees can confirm that and enter something within the chat, that we can then confirm that you guys are seeing it.
I'm seeing 24 participants, so I'm thinking you're right.
Yeah, but I think it actually, okay, Rick, thank you, Eric. And thank you, Nicole. And thank you to the higher power who didn't allow me to say anything that I didn't want to have heard within a larger audience. Okay, we're going to go ahead and get started. Welcome to all. I'm going to hand it over to Kelda for the official welcome.
Thank you so much, everyone, for joining us. The Alaska Mental Health Trust Authority welcomes everyone who is able to attend. I know we're in direct competition with summer in Alaska, which is a tough competition there, especially with the Reds running. So thank you for taking the time to hear about Medicaid administrative claiming. And also a big thank you to our panelists and host HCBS Strategies. Steve?
Yep. Great. So welcome to everybody. We're going to be talking about what might seem like an esoteric subject, Medicaid administrative claiming. However, this has been a very effective tool in other states to be able to draw down additional federal financing for efforts that previously that you couldn't draw down that federal financing for. Starting with the Aging and Disability Resource Centers, and it's been expanded to a broader No Wrong Door effort. What we're going to be doing is then kind of going over who's going to be on the panel, and then an overview of MAC and the No Wrong Door component, and then talking a little bit about Nebraska, because Nebraska has pushed the envelope the furthest in terms of Medicaid administrative claiming for no wrong doors. We are then going to be having the brain injury of Nebraska, talking about their experience and the requirement for implementing MAC. So Ami Patel is from the Administration for Community Living. She actually used to work with Maryland, where we worked with her on Medicaid administrative claiming, and she is their lead on assisting states with participating in Medicaid administrative claiming for ADRCs and no wrong door efforts. And she's going to talk about the federal perspective. Jean Hogan is fiscal program manager within the Nebraska State Unit on Aging. And he's going to talk about some of the Nebraska from the state perspective and kind of give a sense of what the state's experience has been on that. I know we have some of the SDS folks from Alaska here on it. So Jean is kind of the equivalent and can give you a sense of what this entails for a state to be adopting it. Peggy Reisher is with the Brain Injury Alliance of Nebraska. She has gone the furthest, or she was the first one to really kind of get some of the possibilities for the additional funding that they can get. She's going to talk about how MAC has helped out her organization and what it's added to their capabilities, what they are, some of the additional things that they're able to do. I'm Steve Lutzky. I head up HCBS Strategies. For those of you who don't know us, we've been working with Alaska since about 2008. We have a few contracts with the state that we're working with, notably with the trust has been supporting us and giving us a lot of flexibility in how we can help out SDS and other components to kind of build up their Medicaid home and community-based services. And then we're also working with SDS on their No Wrong Door effort. And then last, we have Andrew Cieslinski, who's been working with HCBS Strategies for over a decade and has also been working with Alaska throughout that entire time. I'm going to hand it over to Ami now.
Great, thanks, Steve. And hi, everyone. I'm Ami Patel. I've been here with the Administration for Community Living for over 7 years now, working on all things related to ADRCs and No Wrong Door. And as Steve mentioned, I've been working on Medicaid administrative claiming for several years now, including at the state level in Maryland. So really appreciate the opportunity to be here. And just to start off, when we talk about No Wrong Door, it's really all the efforts states have made in increasing access through a more coordinated system of state and community-based organizations. And it really just going beyond those partnerships between aging and disability networks, but having referral processes in place and more of a systems change approach in involving multiple payers and providers and just requiring broader coordination at the state level. So the No Wrong Door vision has been driven by 4 key functions: state governance and administration, public outreach and coordination, person-centered counseling, and streamlined eligibility. And so ACL has been working with states for over 20 years now to enhance these functions. And CMS, the Centers for Medicare and Medicaid Services, recognize the value of No Wrong Door, and this is why Medicaid administrative claiming is possible, and it's an option for enhancing these functions. So you'll hear more about that, but this is why it's such a huge opportunity for states to take advantage of, and more importantly for Alaska, for maximizing that claiming. And so next slide. Oh, I hear a bit of an echo. Just want to make sure y'all can hear me.
You're sounding clear to me.
Okay, sorry about that. So yeah, this slide want to emphasize how Medicaid is a foundational partner. So all of the community-based organizations and local partners listed here make up a state's No Wrong Door system. And it certainly goes beyond just the ones here, but thinking about the day-to-day services that are offered at all of these entities. So the application assistance, assessments, person-centered planning, care coordination, they all can be sustained through Medicaid claiming. And it's important to recognize that the Medicaid-related activity is already embedded in the day-to-day work at these organizations. So it goes much more beyond than just AAAs and ADRCs. We have a handful of states that have centers for independent living participating. And as you hear about today, brain injury organizations. So expanding on Medicaid claiming is one way to diversify the partnerships and support broader sustainability across the efforts to increase access. And so next slide, as I mentioned, CMS put out guidance specific to No Wrong Door claiming, again, recognizing why claiming is an important factor in No Wrong Door, and it's been a priority for ACL as a sustainability strategy overall. So again, just really important to recognize that CMS has specifically called this out. This guidance document has some really good descriptions on the value of having partnerships with Medicaid. So I'll put a link to this guidance in the chat. We also have several other technical assistance tools that I can link up. But Steve and Andrew are going to do a really good job now just talking about how claiming works and what that process looks like. So back to you.
All right, and so next we're going to provide an overview of MAC and kind of what it looks like. This is something that we want to make sure that everybody has kind of a baseline understanding of MAC, because it is something that the ADRCs and the DDRCs are currently participating in within Alaska, but there's also an opportunity to expand and enhance what's currently being done. So what MAC is it's providing matching dollars, generally 50-50, and that's what it is for Alaska, to cover activities that contribute to making the Medicaid system more efficient and effective. So that can include things like information and referral, case management, activities that are helping people get to the right place or explore alternatives to Medicaid. And so because you're making the Medicaid system more efficient, you're helping divert or delay individuals from receiving Medicaid, the purpose of MAC is going to be getting some reimbursement for that time you're spending doing those activities. Your state dollars, private foundation funds, other non-federal funds can be used as match. So there needs to be some sort of state or local match that is included within the consideration for it. And so when we also talk about like smaller nonprofit agencies or local or community-based organizations, that's where we also see that there's foundation funds available. There's also the state trust funds. There's also other monies that you're making go further by tying them to Medicaid administrative claiming. not only are you making them go further, but it's also sustainable. It's a sustainable source of funding. So, excuse me. And so if the state is looking at where to cut funds, if you're able to attach Medicaid administrative claiming to those funds, that becomes much harder to get rid of because you have a 50-50 federal match coming back on the funds that you're already expending. So as long as you're operating your MAC infrastructure, those funds are going to keep coming in and they are sustainable. It's not a grant where it's just going to go away. Next slide. And so why agencies should look at pursuing MAC. So it can cover a large portion of the budget for agencies. In Nebraska, we'll talk about what that looks like. But for some agencies like Peggy's agency, that means over $400,000 a year is coming back just through federal match. And so that is not an insignificant number. And for larger agencies, larger ADRCs and other community-based organizations, we see that number approaching $800,000. And so that's something where it's definitely a major potential driver of funding. And it, like I mentioned, it also strengthens that case for state and local funding. You can go to your funding partners and say, you know, not only are we doing good work with the funds you're providing with us, we're also getting a 50-50 federal match on those funds. We're making your funds go even further, which makes the case in grant applications. And when you're approaching additional funders, those monies can go even further, and it gives you a much stronger case. It also doesn't require any major changes to your regular operations. What MAC is doing is documenting how much time staff are spending on Medicaid related activities and what those activities are. And what we mean by Medicaid related is not the service piece. Medicaid administrative claiming is the administrative functions that are related to the delivery of services. And so that's where we're talking about information referral, case management, options counseling, supporting the applications that are completed. All of those activities that staff are already doing, we're just capturing, and we're getting reimbursement for those activities. Next slide. And so I've mentioned a few times what might be eligible. So you hear like information and referral, you'll hear options counseling, service coordination, benefits assistance. So that can include helping people understand their benefits through maybe an options counseling process, also applying for those benefits. If you're helping somebody complete a Medicaid application, that would also potentially be an eligible activity. Outreach and enrollment, provider monitoring, planning and development, network development, so doing outreach, talking with other partner agencies out in the community about what you do, how you support Medicaid individuals, auditing, quality improvement, all of these, we've continued to look at additional opportunities. So for each state that we've been working with, we're customizing the menu of activities that are eligible based off of their operations. And so this is not just a very precise list. This could also be expanded depending on the agency's operations. And whenever we bring on a new agency into an infrastructure, we always do a review to make sure that we're capturing all of the activities they're performing. Next slide, please. Okay, so we're going to talk about Nebraska's experience and draw some comparisons to the Alaska system. So next slide, when we did an operational review in Nebraska, really what they thought they had designed their network as was to be a no wrong door network. But what we were finding is that the agencies that were primarily charged with the ADRC role were the area agencies on aging. In Nebraska or in Alaska, you know, the ADRCs, they serve, they kind of have a focused population. It may be the aging population, it may be the older adult, it may be the adult with physical disability population. For the DDRCs, it's the developmental disability population. But because they have that narrow lens, it became readily apparent that there was the need to expand and bring on additional partners who had other expertise serving other populations. And so what that looked like for Nebraska was they brought in their University Center for Excellence in Developmental Disabilities, the Monroe Meyer Institute, so an IDD-focused entity. They brought on Peggy's organization, the Brain Injury Alliance of Nebraska. They brought on Easter Seals, the League of Human Dignity, which is their Center for Independent Living. So that's another huge opportunity for Alaska. And then recently we brought on 211. And 211 is such a major front door for accessing services and supports. If we can, one, have some sort of no wrong door training infrastructure where 211 is receiving training from partners, but then also there's a financial incentive through MAC to be able to draw down those MAC funds if they participate in that no wrong door network. 211 becomes a very big opportunity to help strengthen the case for your no wrong door network. It also is going to help make sure that people are getting channeled to the right place within your network. Next slide, please. And so the reason the partners got brought on is because similar to Alaska, the ADRCs were really good at serving a focused population. And in Alaska, the ADRCs and DDRCs are really good at serving the populations that they're intending to serve. But if we start talking about a more complex individual or an individual who's already engaged in the mental health system or the brain injury system or with the Center for Independent Living, that's where Nebraska saw it struggling, was that the area agencies on aging there were not ready or able to bring the expertise in those cases. And so for the partner agencies that came on board, it really felt like the ADRC, the D in the ADRC, the focus on disability was really not emphasized. And so that was something that they were going to bring that expertise to. Next slide, please. And then Medicaid administrative claiming has allowed Nebraska to capitalize that D. So all of those agencies, they bring on their already developed infrastructure and expertise in providing information and assistance, options counseling, short-term case management, and they're able to draw down MAC, but more importantly, they're able to train their partner agencies on the functions that they play and when the referrals can be made over to them and help understand how this becomes a no wrong door network, because regardless of where I call, I can end up at the right spot. And so it also allows them to enhance and expand the activities that they're providing. With Peggy's agency, like I mentioned, that's about $400,000 a year that they are flexible and they can do what they need to do with those funds to best serve the populations that they work with. And so that really creates an incentive for them to continue to try to optimize their Medicaid administrative claiming, to reinvest in the system and the activities that are getting them that reimbursement and make that system even better. And now I'll turn it over to Steve.
Okay, so when we were working with Maryland under Ami's guidance, we did kind of something that was very innovative for Medicaid administrative claiming. Previously in the past, when people thought about Medicaid administrative claiming, they had it more tightly tied to Medicaid directly, in that you were just looking at people, if you're telling people about Medicaid, or somebody was in the process for applying for Medicaid, or if somebody was already enrolled and you were doing something that wasn't covered by a Medicaid service, that those were the things that could be thought of as being Medicaid related. But we recognized that CMS had actually begun giving guidance that there was a broader set of activities that could be considered Medicaid related when they were doing like Money Follows the Person, the Balancing Incentives Program, most recently under the guidance for the ARPA Enhanced Funds within that on it. And what they're recognizing that if you're working with people who are at risk of going on to Medicaid because they're at risk of going into an institution, that you are actually helping out the Medicaid program. You're diverting people from higher cost services and saving future Medicaid dollars and making the Medicaid program more efficient. Hence, those activities, by under CMS, under Money Follows the Person and the administrative funds, under the ARPA funds, are all things that were claimable for those administrative funds. So we kind of thought that for the Medicaid administrative claiming, that also should be eligible. And that's like a huge change within it, because there's a lot of activities that organizations that are doing that are targeted to more low-income individuals who aren't on Medicaid yet, that they have a disability, that if you guys weren't providing the supports that you're providing to them, that they would likely deteriorate much more quickly and come onto Medicaid at a much higher cost, and that by your interventions, you're actually saving the Medicaid program funds. Hence, that CMS has allowed that in Maryland, now in Hawaii's approved plan, in Nebraska, all to be considering those Medicaid related, which increases the types of activities that would be considered to be Medicaid related. So in terms of how this is operationalized within it, starting in program in Maryland, we set the threshold of that if your income and assets would be used up by a 6-month private pay stay in a nursing facility, that was the threshold of being at risk for spend down. We find that in most of the programs that we're working with in the States, that about 80 to 90% of the people that they are working with fall into that category. And then in terms of risk for institutionalization, typically you're looking at any kind of functioning and impairment of ADLs and IDLs, behavior or potentially harm for themselves, or a cognition issue. And when we're thinking about impairment, we're looking at risk of going into an institution, not that somebody meets like a nursing facility level of care or an ICF, IID level of care within that, because we are deliberately trying to get people earlier to be able to intervene. So under the CMS regulations or guidance, they don't have any definitions or requirements. So it's not like if you're looking at a 1915C waiver that you have to meet nursing facility level of care. The state can define what they mean as at risk of an institutionalization within that. The major concern would be if you have an auditor, if this is kind of a credible definition for it. And certainly any kind of an ADL or IDL impairment, you can see that most people, that there is a clear increased likelihood that they might go into an institution if they're not given any kind of support. We'd also encourage you, we've seen that the chat function is not active, but the Q&A function is active. So if you do have questions along the lines, please feel free to use the Q&A functionality within it. We will get to those questions, and we're going to have questions and answers periods afterwards. And I think we might be able to unmute depending if Zoom has changed their functionality again between last time that we did this and this time. Okay, so the expanded definitions means that MACs become a primary source for funding for many of the disability partners. It's become a key component of it for that. So the key thing that you're going to be looking at is that if these disability partners are performing these activities, that they're working with these at-risk populations with disabilities, doing something to help them to remain in the community. And the other component is whether there is non-federal matching funds that can be used for that. And so that's something like in Nebraska that we looked at very carefully on that. That for the disability partners, we realized that they had a lot of funds that they had been raising. So like Peggy, they have a big fundraising effort every year. They raise a lot of private money within that. All of that is eligible for matching funds that could be matched within it. If you're getting grants from foundations that aren't directly linked to providers, there's some questions that we need to look at like that and get into some of the details if you're interested. But those kind of grants typically can be used for match. And it also does start to give a leg up when you're trying to get additional funding for it. So a lot of the disability partners in Nebraska have used this when they're applying for additional funding to talk about, like, you get the 2-for-1 match in that on that, and it makes it much more attractive for other funders to invest their funds in the disability partners, and kind of makes it easier to draw down some of those additional match within that. And we know that many of the existing ADRCs and DDRCs in Alaska, that you do a lot of work outside of the ADRC and the DDRC, either as your role as the SIL or as an Alaska Native organization working with other individuals that is not necessarily matched currently at this point, but has the potential to, because it falls into those activities where you're helping people to kind of remain in the community, and that you have other sources of match, whether it be monies that you're raising, money from the Alaska Mental Health Trust, from MATSU, from, you have a whole wide variety of different organizations that are funding services in addition to Medicaid. Okay. In terms of the funding on it, that we started out, when we started this in the second quarter in 2021, where the overall claim was about 405,000. So it was about 1.6 million that was annualized on it. We've grown from there to 2024 to a claim of 1 million, and we've crossed this quarter 1 million and a quarter. So right now we're at 4.1 million at an annualized component for that. And, as comparison in Nebraska, Nebraska has a population of about 1.9 million people. So that gives you a comparison for Alaska. And Nebraska has a state-funded program called Care Management that does receive some funds on it, but I think Alaska likely does have a lot more of state-funded or other sources of non-federal funded programs that could be potentially eligible for that. So that's a big factor within that. So we've seen some growth. Some of the growth that we've seen in Nebraska is due to some of the participation of some of the individual agencies that we saw, like, the disability partners have really taken off, where they were only getting 33K from the original claim in 2021, and now they're receiving about 400,000 per quarter. On average. So we've seen a lot of growth within that. Adding 211 has been a huge component. Andrew, what's the Medicaid related percentage that we're finding from 211 now?
Right about 68%.
So over 2/3 of their budget is potentially claimable. So if you take and it's a 50-50 claim, so that means that for 211 they would get the equivalent of more than 1/3 of their budget back in match for it. So it can become a huge source of funding for them. We saw some growth in the disability partners, in that a lot of that is then related to the increase of the Medicaid-related time. So when we're setting up the Medicaid-related time components, it's important to get the code set up accurately and in ways that maximize the amount you can claim. We just did an analysis in another state that's actually set up not too different from Nebraska, and the way they've set up their codes, they're only getting 10% claimable on it. So we talked about, like, there's some huge differences that you can get. And when we did that in Nebraska in the first pilot without any of the other training and infrastructure, we got about 55% that was claimable. We've been subsequently working with them and establishing some good program infrastructure for it, and gotten that claim up to about nearly 77%, which I think is probably on the high side of what you potentially can expect for that. But that is, a really great claim percentage. It's meaning that about 37-38% of your budget is what you will get back in the actual amounts. It does differ a little bit by the different partners, but a lot of that is on how carefully that they're watching what they're doing, and getting some good information about being able to what they potentially can claim. So, a takeaway from that is, if you just set it up right from the beginning, get some good codes, that you'll get at least a quarter of your budget or so drawn down from the match. But you can up it to, for another 10 to 12% of your budget, the equivalent amount that you get if you set up your operations on it, and you get far more return on your investment by kind of doing this and kind of spending the time in doing this accurately. The other thing that you get by from getting from, like, this original 55% to the 76.9% is you get a much better audit trail, because you're getting information that you're using to identify people that are incorrectly coding their time, and coding things that are not Medicaid related that should be Medicaid related. So you're getting more money from it, but you're also getting better documentation in case you're ever audited from the feds, which is infrequent, but it does happen. And we also always caution states. So we want to look at not only the ability to draw down the amount of money, but we want to make sure that if you are ever audited, that you have a good trail so that you don't get into disallowances. So with the enhanced infrastructure, you get a much stronger audit trail. So if they start to look at individual records, it's much less likely that they're going to find anything that is faulty within that and lead to any kind of a disallowance. So I'm going to hand it over now to Peggy. And Peggy, you're muted. Okay.
Now I'm not. So good afternoon. I'm assuming it's afternoon wherever you are, but maybe it's morning.
It's morning there.
It's morning there. All right. Well, good day, maybe is the better way to say it. So I'm Peggy Reisher. I'm the Executive Director for the Brain Injury Alliance of Nebraska, and happy to be here with you today. So a little bit about our experiences here at the Brain Injury Alliance. We have a staff of 10 and a half of us. And actually, I think we do need to up this. We've actually just have 9 staff participating in MAC at this point in time. We have some part-timers, so that kind of throws our numbers off. But we only have one of our staff members not participating in time studies at this point. As you can see here, we have our first claiming, we only had 2 staff at that time. And I really do commend MAC funding to actually be able to say this is why we have more staff at this point. But our reimbursement early on was around $26,000. We were that group as we were filling out the cost pool sheet. We thought, boy, if we make a couple hundred or 1,000 even at the most, we were going to be feeling like this wasn't worth it or not. But so when we saw the first check was right at 26,000, we were shocked and amazed and very delighted. Our last quarter reported cost, we received over $131,000 in reimbursement for us as a small organization. Our budget runs right around $1.2 million. So this ends up being a fairly significant amount of our budget. When we put together our 2024 budget, it was about 30% of our budget, which has really given us a greater opportunity to do several things. And I'll have you go to the next slide. So what we do with these funds, we are very, very thankful for Gene and his crew over at the Nebraska State Unit on Aging to allow us lots of flexibility on how we use the funds. We do really work hard to reinvest them in our organization. And we are doing that, as you can see here, we do that for wages for resource facilitation staff. Again, it's really increased our ability to bring on more staff members. When we say resource facilitation staff, just to define that, essentially, our organization is providing information referral as well as case management types of services for folks with brain injury across our state. And we, at this time now, are able to have somebody located in every part of the state, whereas when we first started this, we had just one person doing all of our resource facilitation work. So it was very stressful for that one person, and we didn't have nearly the reach we needed. We are, the funds also allow us to offer more staff training. I'm delighted to be able to, when we bring on staff, to say, yes, we actually have funds for training and professional development, and also can have them participate in different events, even state, national events that we now have the funds to get people to. It has also helped us with our strategic planning, the funding for strategic planning. Probably one of the, next to the wages for resource facilitation staff, I think our biggest benefit is we now have money for database upgrades. That is something that we used to never have. So we are now able to bring on, a database that's really helps us tell our other funders what it is that we're doing. It has also allowed us to do more marketing and outreach. We utilize some of those funds to help pay for our little TV commercials in different parts of our state. So it's been a true blessing to be able to utilize these as our organization has felt it needs it. So for that, we're very thankful. Next slide. So I was, and Steve and Andrew know this, but I was one of those naysayers when they first called. I avoided them. I kept saying, we as an organization don't bill Medicaid. I don't know what you're wanting from me. I was polite. I was Nebraska nice about it. But I'm just like, I don't get what you guys need from me. I don't bill Medicaid. And it took me a little bit to let that sink in. Like, oh, okay, this isn't really Medicaid. They were very patient with me. They said, well, we're going to have you do these time studies, and we haven't talked about time studies yet, but I was like, oh my word, do we really have to mark down what we're doing every single minute of the day? I'm like, oh gosh, that's just too much work. They have made it very, very easy. It sounded scary. It sounded like a lot of work, but at this point, it takes probably all of 20 seconds of my day, twice a day. And it's been very well streamlined and very easy. And as you can see here, I mean, Stephen and Andrew have been wonderful tour guides. They've been very patient with me and our team as we learn more about Medicaid administrative claiming. And they have developed these monthly reviews, which get sent to all of us as directors or executive directors. And it has been, you know, I have to admit, when I get those monthly reviews, it's like, oh, shoot, got to take the time to do those. But honestly, it has helped us as an organization and my team to really do better, to make sure that we're tracking things in the right way. I share usually the reviews with the whole team, and we learn from each other's mistakes. And for that, I've been very grateful. There's been times when it's like, okay, now I need to hit this a little bit harder, and how can we continue to improve our amount of Medicaid claiming? And I know Andrew gets called frequently. It's like, hey, we need to know a little, you know, review again for our team, or as we have new folks coming on. He's always very gracious in providing some training. So even though this whole thing seemed kind of scary, I've been very grateful for the folks over at HCBS to help us through this process. We are one, Stephen mentioned it, but we are one that we talk a lot about Medicaid administrative claiming when it comes to writing our grants, and have been really able to maximize that and use that as our flashy reason why they should fund us instead of other people. Next slide. So this is just a quick little case study. This is an example of the type of client we would be working with. Just to give you the overview, Christy, who is one of our clients, name changed, but she had incurred a stroke. She was actually in Colorado. She had done some rehab in Craig Hospital in Colorado. She moved here to Nebraska to be closer to her boyfriend at the time. Long story short, he ended up leaving. She was needing to have some support and some assistance. Her sister and family lived in Ohio. Her mother lived in Colorado. Anyway, she was here all by herself. Thankfully, she reached out to our organization, and we don't make brain injury go away, but what we do is provide assistance to help people kind of thrive in the community. And she was one that ended up needing to go on Medicaid, but when we started working with her, there were so many concerns for her safety. She was having troubles with her medications. Because of her brain injury deficit, she had problems with reasoning and problem solving. She didn't have great insight to her deficits, so we provided some education there. She had some physical disabilities. She was reporting falling frequently, symptoms typical of brain injury, some headaches, fatigue, anxiety, depression. She also had a history of an eating disorder, was bipolar. Anyway, she was a little bit of a mess in some ways. So our resource facilitators started working with her. In the next slide. Things that we did to help her, and these are all great examples of ways in which, you know, we're able to build towards Medicaid administrative claiming. We worked with her and her sister to complete the Medicaid application. We applied for the age and disabled waiver. We helped her set up therapy to help her with her balance issues, helped her, you know, work with the YMCA to get a sliding scale fee to use their equipment, so she was also able to do some socialization while she was at the YMCA, but also because she cared about fitness, was able to feel better about herself after that. We also helped her line up a medical professional with some experience in brain injury and bipolar. We helped her set up some goals, just like what do we need to do to help alleviate some of this isolation. Helped her identify volunteer possibilities, helped her and her sister set up a bill paying system, and overall just, assisted her with Medicaid management. We aren't, again, ones that take over, but what can we do to help set up that system? So as you can see, all those things we're really working to help keep her in her home and out of a facility, because she's one that probably would have showed up in a facility if she wouldn't have had the support that she needed in the community. Again, all examples of ways in which we were able to maximize our work with her. This is stuff we were going to be doing with her regardless, but to be able to utilize the Medicaid administrative claiming to back up and to help fund some of our work is was really a blessing. So that is my story. Next slide. I think from here it goes to Jean.
Actually, no, to Andrew, I believe.
Oh, Andrew.
Yep.
Okay.
All right. And so Alaska does have, as I mentioned previously, Alaska does have administrative claiming for the ADRCs and the DDRCs currently. So infrastructure exists. However, the infrastructure that's available can really, there's an opportunity to enhance it significantly, both to improve what's going on at the ADRCs and the DDRCs, but also to expand it into other entities. And so when we're talking about the infrastructure, what we want to go run through now is really what we mean. So one is we need to establish costs for staff time. And in Nebraska, what that looks like is a twice a day random moment time study. So while some states have set up 100% time documentation, or maybe you get a completely random sample where one day out of the month you might get 10 surveys, and then a week later you get 3 surveys on one day, and then there's a 2-week gap, and then maybe you're getting 5 surveys in a single day the next week. And so it's while it is truly random, you're not getting a good picture of how that employee is spending their time. The 2 per day that Nebraska is doing allows you to get a picture of what's actually going on with that employee. We're able to provide Peggy with a report each month and all of the agencies with a report each month that says this is how you're, out of the 44 approximately surveys that your staff responded to, this is what the results were for each of those time studies. This is what they said they were spending their time on. This is how many individuals they were supporting with Medicaid related tasks. This is their responsiveness of each of those surveys. And like Peggy mentioned, we're seeing these take roughly 40 seconds per survey. So they get one in the morning, one in the afternoon each day. And the only complaint we really get about that is when people don't get their surveys. And so the other piece, so the time study, it says this is how much time your staff are spending on Medicaid related activities. The other piece is the cost pool. And the cost pool is documenting all of the costs related to staff providing that support. And so you have to be able to document the costs that you're requesting reimbursement on. And so in Nebraska, what that looks like is each staff, we have their personnel costs, we have their travel costs, we have their costs related to utilities and building rent, and all of the things that they need to do to perform their job are included within that cost pool. So those 2 things together, we have the time that you're spending on Medicaid related activities. We have the cost associated with it. We combine those, you get your 50-50 match on the resulting amount. And that's ultimately what we get back. That's a very quick, in a nutshell way of how it's calculated. There's a lot more nuances that go with it, but that also means there needs to be agreements. And we'll talk about what those agreements are, but next slide, please, Steve. So your time study codes, we need, like I mentioned, that time study needs to say, what were you doing? How are you spending, and who are you supporting? Were you supporting somebody who is on Medicaid, who is at risk of spend down, that concept that Steve was talking about, where they're not on Medicaid, but a 6-month nursing facility stay would deplete their income and assets to the point where they would be eligible for Medicaid, because both of those are reimbursable. Were you working with somebody who's not on Medicaid, or you weren't having a Medicaid related conversation? Or maybe you were on vacation, or maybe you were at a training that had nothing to do with a service. And so that would be more of a general administration activity. So the time study allows us to categorize staff activities. And then the codes that we want to select. And again, there's a coding schema that exists within Alaska already for the ADRCs and the DDRCs, but there are opportunities to enhance what's currently being done. Because there are additional activities, there's a population, that spend down population that could be added that's not currently captured. And so that's also something that is out there. It's been approved by CMS previously in other states. And that's always what we're looking for, is what's been approved, because we want to make sure that we can get that infrastructure approved, but then we can start working on what we can do to kind of push the envelope a little bit further. We also want to make sure that codes are reflective of what staff are doing. So as we're looking at both at the ADRCs and the DDRCs in Alaska, and then beyond at other agencies, that's where that operational review becomes really critical, because other agencies may be doing something completely different than what the ADRCs and the DDRCs are doing. We don't have the codes that are capturing that activity, and we want to make sure that we do. So we in Nebraska, we did a quick review of their operations. We would expand codes, we would update things, but we always made sure that we kind of stayed within what had been approved previously, because this has to make sense to workers. When I get a survey and I'm calling it something that you're not used to hearing, like if your information referral is called something different in your agency, we need to make sure that we're reflecting that concept so that way it's making sense to your staff. Next slide, please. And then the cost of staff time, like I mentioned, in Nebraska, this is done in a cost pool that's submitted each quarter. So we just wrapped up one of the quarters. The agencies submit their cost pool, and in the cost pool, they submit for each staff participating in the time study, they submit their personnel costs and all other associated costs, because the more costs that you can attribute to a staff, the more you're able to claim. And so we also we don't just look at the personnel costs, we look at travel, we look at the utilities, any sort of building rent, any sort of communication or computer purchases or anything like that that can be attributed to an individual or spread across an agency. We're able to receive reimbursement for all of those activities as well. And so the cost categories, what we've done in Hawaii and in Nebraska is we've looked at what the state cost categories are, and we've aligned the cost pool with those state cost categories. So each state's unique in that way, but we don't want to just confine this to, personnel and travel. There's also a lot of other expenses that are going out there, and all of those can potentially be eligible for reimbursement as well. But it's really important that you have a solid infrastructure for documenting costs, because when CMS comes back and they say, hey, can you demonstrate why you requested these funds? We need to be able to have a solid foundation to be able to say, this is our justification for the costs that we reported. Also in Nebraska, there's the opportunity for this each quarter, we compile the cost pool on their behalf. So that's one of our functions. We operate the time study, we compile the cost pool. In the state, Gene's going to talk about this in a little bit about what the responsibilities of the local agencies in the states are, and also his general experience. Hogan is our primary point of contact at the State Union on Aging in Nebraska. He reviews these reports. I would guess this takes less than an hour of his time each quarter to be able to make all of that happen, but I'll let him speak to that because that is my guess. But if we can go to the next slide, please. So the agreements and approvals, so these have been sorted out in Alaska already, because we do have the existing claiming infrastructure for the ADRCs and the DDRCs. So the funds have to flow from CMS at the federal level to the state Medicaid agency to the operating agency overseeing the local agencies. Now, it could be that the Medicaid agency directly oversees the operating agencies and those funds flow out from there. But in Nebraska, what this looks like is that CMS channels the funds to the Medicaid agency. The operating agency, which is the State Union on Aging, they oversee the contracts with the ADRCs and with the other partner organizations. So they each have a contract with the State Union on Aging. And that is really just to allow for the fund flow. There's a minimal amount of state funds that are also available through these contracts, but that's not necessary. The additional monies from the state funds are not necessary to be able to draw down MAC, but there does need to be some sort of agreement between these agencies to make sure that the fund flow is established. There's also the ability for, at any point, for there to be some sort of set aside. So right now, the State Union on Aging does in Nebraska, they don't have any sort of administrative fee for overseeing this. In theory, they could have some sort of set aside that they have to be able to fund initiatives and opportunities and grants for the AAAs, but everything right now is just passing directly through the State Union on Aging to the ADRCs and the partner organizations. So that's also a consideration in Alaska, is that there could be some sort of set aside if there's at SDS or a different entity, if there's a desire to be able to have some sort of administrative fee that you're able to use in a different way. All of this has to go into the cost allocation plan. So the state's cost allocation plan and CMS has to approve that. So all of the methodology has to be at least referenced in the cost allocation plan, and that in Hawaii and Nebraska, they're relatively straightforward amendments to the cost allocation plan. They reference the methodology, so how we're operating all of the infrastructure, the time study, and the cost pool, but it's not directly described within the cost allocation plan. So next slide, please. And now I'm going to turn it over to Gene to share his perspective. We do have these as formally written as state unit responsibilities and local agency responsibilities, but also, Gene, if you just have any lessons learned or takeaways or what SDS in Alaska may expect from some sort of enhanced MAC process, that would be helpful.
Sure. I'm Gene Hogan. I'm the Fiscal Program Manager for the State Unit on Aging. We are part of the Department of Health and Human Services for the state of Nebraska. And as on the previous slide, like the Medicaid agency and the State Unit on Aging were pretty much the same, so we have not needed an MOU, but some states have. So with regard to running time studies, gathering cost spreadsheets, we do contract with HCBS Strategies to do that. We are a participant in the quarterly work groups for Medicaid administrative claiming. We are a point of contact for agencies if they have questions about time studies and that sort of thing, or like gathering their costs. A lot of agencies, since they submit reimbursement requests to us, they have already established some of the costs for those services, and then they are just able to piece out what staff maybe are included in the time study and which aren't, and just submit an adjusted cost pool spreadsheet on a quarterly basis to Stephen and Andrew, and we submit one as well. Ours is probably much simpler than what the agencies submit, but with our quarterly claim that we receive, the quarterly invoice for reimbursement, all of those costs are detailed and all of those funding sources are detailed. And we're aware of a lot of those funding sources because we also provide their state funds to some of the area agencies on aging, and then we also provide the ADRC funds. And ADRC was kind of the mechanism for bringing all of these agencies together. It's a very small pool of funds for aging and disability resource centers. It's only about $613,000, but that's kind of how that's initially how we brought our 8 area agencies on aging into Medicaid administrative claiming, and then getting those other agencies on board with providing information referral or options counseling or benefits assistance. That's kind of how they got their foot in the door for Medicaid administrative claiming. And then we have also established all of our contracts or subawards with those 13 organizations to include this Medicaid administrative claiming. And then we have stipulated in all of those agreements that they'll participate in the time studies. They'll participate in the supervisor review that Peggy was referring to, the monthly supervisor review of the 5% of random moment time studies. And then they'll also participate in the work groups and the ongoing training, and then submitting their quarterly reports to us. And then we submit, and then we disperse the reimbursements to the 13 agencies. It is easier with the disability partners because we have put a kind of a not to exceed amount in their agreements. With the other agencies, we've had to add all of those quarterly amounts to their subawards on a quarterly basis. So that's a much slower process. And then like the quality assurance and the compliance piece, it's not only participating in those quarterly work groups or assisting any of the 13 agencies with any kind of training or answering questions, but it's also on our side, it's working with our budget office as they prepare the CM64 that they submit to CMS, and it's identifying those costs. And I've got one of those to work on this week, just to kind of provide a overview of the funding sources that are being used for Medicaid administrative claiming on a quarterly basis. So when they submit that report to CMS, they can submit it with confidence that we've actually done our due diligence. You can turn to the next slide, Andrew. And I think Peggy's talk about ensuring all the appropriate staff performing the reimbursable activities are participating, I think that kind of highlighted what Stephen was saying earlier for me about the claim percentage going from 60.5% to 76.9%. A lot of that is just the agencies reviewing who is participating and who are the staff on their payroll who are actually providing the most Medicaid related support for their clients, and then including those people and maybe shifting people on and off of the time study to maximize that claim. So the fiscal spreadsheets that we get, those include all of the non-federal sources of funding that our agencies receive. So our area agencies on aging, they get state funds that we provide to them. They get the ADRC funds, they get the care management funds, and then our disability partners like university, they will get state funds, they will get foundation money that will be unrestricted, and then our disability partners will get their funding from a variety of sources. And then as far as attending trainings and participating in time studies, that is just provided on an ongoing basis as we bring new agencies in, as we bring new staff in. Those staff are trained on how to complete those time studies. Those agencies are trained on how to participate in the whole process. And then I am a recipient of all of Andrew's emails reminding people to submit their cost pool spreadsheets, and those go out on a regular basis. I don't know that we've had any non-compliance, but I get to see who is cutting it close, and it's usually me, one of them. But yeah, I will turn it back over unless you have questions.
Great. And I think we can just open it up for questions and answers on it. I've enabled all of you so that you can potentially unmute yourself and ask any questions. You're also welcome to ask any questions in the Q&A option. So we can open it up for questions or other discussion points.
Ami has provided the CMS guidance in the chat.
Yeah.
Well, I will get us started with a question or two, if that's all right. What about working with some non-traditional partners that may not be Department of Health grant recipients, such as homelessness service providers or people who work with the reentry populations?
Yep. And some of those populations are very risk of going into institutions and are likely to be going on to Medicaid. So it certainly would make sense to be working with them and drawing down Medicaid administrative claiming. And Ami, I don't know, because any of the other states that have been working with this had like things like homelessness or reentry yet?
Not that we're aware of, no.
But it does make a lot of sense because these are some of your most vulnerable populations, and that they certainly can benefit from Medicaid and from some additional coordination.
And just to get a little further into that question, would something like outreach to connect people to health services, insurance, behavioral health services, or disability services, would that be a type of service that could qualify for Medicaid administrative claiming? I know the devil's in the details, but just kind of
No,
generally.
yes, it certainly could. The things that we'd be looking for is, one, if the outreach that they're looking for can be tied directly to them getting onto Medicaid for it. So if you had a combined SNAP Medicaid application within that, certainly, then that would be something that would be qualified. Or if this is like a precursor step, like they want to get a disability determination to be, which will allow them to get onto Medicaid, so that could be considered Medicaid related. If it's a program that's more like something that's targeting the social determinants of health and other things that might be helping them in, then you would be probably wanting to look if that person is really potentially at risk of spending down and going into Medicaid on it. And if that person is, that becomes an activity to help them remain in the community. So then those types of activities could become claimable. And we've had a lot of success in terms of how we've set up the codes to make sure that as much as possible that those activities could be considered claimable.
I could add just one other example of what we've done here at the Brain Injury Alliance. We do a lot of outreach, especially in areas of justice involved in homeless programs and domestic violence, because we know there's a high prevalence of brain injury in those populations. So as we go in and do trainings with those populations about brain injury, we do talk about Medicaid administrative claiming, so that we can or not Medicaid administrative, but we talk about Medicaid, and that's what our resource facilitators assist, getting people connected to those types of services and support. So then you can kind of tie it back to you're doing the outreach for those programs, and again, utilize that presentation opportunity as a way to, again, be able to do some claiming on that.
We welcome for any of the attendees that are listening in. If you're working with the organization, if you want to describe some of the things that you're doing, you can we can test us to see what we think might be claimable or not claimable.
Hi, my name is Rob Lamont. I'm with Alzheimer's Resource of Alaska. Thanks for the presentation today. We have a lot of care coordinators in our company and work with folks that have Medicaid. Some folks that don't qualify yet are in senior in-home. So I was just curious as to how that would work for our agency. I don't want to make any assumptions, and I've listened to everything you said, but I just want to see how that MAC would fit in because it sounds like some of the things that we already do fit into the MAC kind of protocol. So maybe you can help us understand that better for how it would work with us.
Oh yeah. There's a lot of things that you guys are doing that potentially could be Medicaid administrative claimable within it. When you're looking at, because I know you do a lot of information and assistance with individuals, some things that are some service coordination that could be considered short-term case management. The vast majority of the people that you're serving are going to be more low income. If they've got dementia, they're falling into the at-risk. So I would think that you guys would likely have a very high percentage of your time that's Medicaid related. So a lot of the staff that you have in-house that are answering those phone calls, that are working with individuals, we know you guys do some things in terms of the family caregiving. If you're doing things that are going beyond the federal grant that you're getting through SDS on that becomes claimable also.
Okay, so it's basically a supplemental and an additional to what we're already getting. That's fantastic.
Yeah, the key thing would be to look in terms of if you have sources of non-federal funding that could be matchable. So looking through some of the stuff that you're getting through the trust or through your own fundraising or directly from the state, from the non-federal funds on it, I would have, I think there's a huge amount of opportunities in terms of the work that you actually do, it being Medicaid related. The thing I don't know is how much of your funding is non-federal, but we'd be happy to have further conversations with you to help you guys figure that out.
That would be fantastic. Thank you so much.
Patty, go ahead.
Hi, Steve and everyone. I'm Patty Raymond Turner. I'm the coordinator of the Brain Injury Council of Alaska. Glad to be here. Thank you for the informative presentation. And I'm going to throw out another example to see if, in your opinion, it would be the type of service that could be claimed under Medicaid claiming. Our organization, UAA-CHD, does a lot of like virtual education. We have had a series for caregivers, for example, in the past, as well as family members. So going along the lines of thinking that perhaps that would enable caregivers to provide enhanced care in the home so that the person is not institutionalized. Would that be a type of service that could be, in terms of time studies, be identified as something under Medicaid claiming, administrative claiming?
Yeah, it all could. The devil is in some of the details too, in terms of if you're providing this to a group versus to an individual. So in both cases, there could be pathways that we could find for it to be Medicaid related. For the individual, we'd want to be looking if it's like initial information referral, and as part of that information referral, when you're describing these other things, if you're thinking about should I be routing them to Medicaid as a component, and if that's where that's occurring, then that could be Medicaid related. If you're beyond that and providing more general training to a larger group of people, if you're including like that focus in terms of Medicaid as an option within that and the supports within that, then we could try to make that Medicaid related. If it's to an individual, then you'd be looking if that individual is at risk of spend down on that. In that case, then you get to the point where that is claimable. So I know we talked about like this, you don't need to necessarily change the way that you do anything to be participating within this. However, there can be tweaks about how you do things that make more of the things that you're doing Medicaid related. I'm fairly comfortable talking about it because the tweaks are to emphasize the role that Medicaid plays and how you can access Medicaid as part of your ongoing operations, which given how important Medicaid is as a funding stream for individuals, I think it's really beneficial for people to know more about it and be able to streamline the access and be able to get that for it. So I think that if you're tweaking your operations so that it recognizes that central role of Medicaid and you're educating people about it, then it becomes Medicaid related. So I think you get more money for doing something that probably enhances what your program is doing.
Thank you very much.
Yep. I mean, some of the other things that you guys do too, like the brain bus and stuff like that, all of that potentially could be claimable too. Other questions, or people want to throw something out here to challenge us on it?
I have just a quick or question about institutional care or what counts as an institution. Does Medicaid consider corrections to be an institution to be avoided for this kind of funding?
Well, and we want to create a clear separation that Medicaid administrative claiming is not like a 1915C waiver or another Medicaid funding authority. So we're not limited to like the definitions that they have for nursing facility level care or another component within it. The key thing that we're looking for is that you're doing something that's making the Medicaid program more efficient and effective. So that you need to be making that argument that what you're doing is making the Medicaid program saving them money or making it more effective at supporting individuals consistent with the goals of Medicaid. So when we're looking at corrections on that, if it was something that's just avoiding prison, I'm not saying like, how do we make that connection directly on it? But if you give me some more specific examples, like the types of programs that you're looking at funding on that we can see if there's a credible case that can be made. Certainly reentry. prisoners with people with disabilities that are going to be coming out and then entering into Medicaid. You're talking about then that transition to the Medicaid program, so they have a more smooth entry, so that they're more likely to be in less expensive services. That once they get in Medicaid, and that when they're on Medicaid, they have fewer negative outcomes from it. Those kinds of things seem like they potentially could be eligible. We do want to, if we're going that route, we do want to do our due diligence. We want to look if there's any other components within the federal regulations or other requirements that prohibit it on it, because we want to push the envelope and be expansive, but we also do not want to do anything that if there's an audit in the future that puts the state at any kind of risk.
And how would you handle services that could be considered direct services as well, like case management or patient navigation?
Well, there's not strict rules of the road on it, but generally something that's a Medicaid service that CMS can be less comfortable with claiming it than something that's not. With case management and these kinds of service coordination, that's kind of the exception to the rule on it. At one point, that CMS tried to make a clearer distinction between case management that can be funded administratively versus what might need to be funded as a Medicaid service. And they issued some proposed guidance on that, but they kind of pulled that back and backed away from that subsequently. So there's lots of states that do, full-on waiver, 1915C waiver case management, and do it as an administrative cost. So there's lots of examples in which this case management, information referral, all of those things have been claimed as administrative costs within that. So it's pretty comfortable within that. When we get into some other things and some of the gray areas on it, it does become more gray on it. We're happy to have discussions with an individual service to see if there's a credible case for it, but then it comes down to how comfortable is the state in pushing the envelope a little bit further. We talk about we want to push the envelope, we don't want to tear the envelope. Talking to the state to see if they're comfortable with it, and then talking with ACL and CMS to see if they have issues with doing something.
Yeah, and just to add to that, I think the main thing to consider with case management is that there isn't already some sort of reimbursement from Medicaid for it. So is it already fee for service, or are they billing separately for case management? Because there can't be double dipping to then leverage Medicaid administrative claiming. So
yeah, and we consider double dipping, that the same organization's getting paid twice, but we're also want to be aware of duplication, that there's not like another entity that's getting paid currently to be doing this case management that you're then kind of claiming for because you're doing it what the other organization should be doing.
And from the chat, Sandra had asked, when the reimbursement's received, are you required to reinvest those funds specifically into Medicaid-related activities, or are the funds associated with the reimbursement considered for free use for wherever the organizations needs to invest them? This is a state decision for how that's set up. And so in Nebraska, the agencies receive all of the reimbursement that they are owed directly. And so all of the claim amount that they report, they get back directly. In other states, they may have it set up where there's some sort of set aside or administrative fee for that as the funds pass through that the state may withhold, or there may be specifications on how the funds are spent. So it's really a state-by-state decision and how that's made.
But overall, just remember that this is reimbursement for money that you've already spent. So it's coming back. So from the federal perspective, they're just paying you back for their share of the services that you provided. Most of the states provide some flexibility for how you're going to be using those funds. But again, that's kind of a state decision if they want to place any additional requirements on it.
And in Nebraska, they've kind of taken the approach that your agency knows how to best serve your population. So we're going to allow you to reinvest those funds as you see fit. There's also from Jacqueline in the Q&A, Health TIE is a nonprofit program that helps support people with behavioral health, SUD, IDD, and Alzheimer's and dementia. We work with new ideas, often technology-based, that help people remain or be independent. Would introducing something new and creative be appropriate that addresses workforce issues while also keeping people out of institutions. Would that be appropriate for these programs? So as Peggy mentioned with brain injury, they have their core functions that they perform. So they have the information referral, they have their short-term case management, benefits assistance, and other things that they're helping do. But they're able to take these MAC monies and use them for other innovative projects, for their database realignment, for other things that they want to invest in. So that would be something where, yes, you could use MAC funds for that, whether the activities that you're performing, and so yes, you can use MAC funds for that. If the question is, are these activities we're performing, like the new and creative approaches, reimbursable? That would be kind of we would need to get more into the details about what that actual activity is and who's being served by that activity.
But if it is something that's supporting somebody to have a job or remain in a job for it, especially if it's somebody that's an individual with a disability that's relatively low income, and then this is providing a source of income for them to be remaining off of Medicaid and remaining independent, then I think you have a case to make that this should be considered Medicaid related. Again, it would be going over to the state, making sure that the state's comfortable with the definition within this. We'd want to look also if it's somebody that's already on a waiver and there's a supported employment service within that. We want to be very careful to make sure that we're not duplicating anything that they already potentially should be getting through another source.
And in Nebraska, they do have a service called within their taxonomy called technology and equipment. And so the actual equipment cost, that's not eligible for reimbursement, but the staff time and helping support getting that equipment ordered and providing some oversight, as long as that's not reimbursed through another source, that time is administrative time that is eligible for reimbursement.
And we're seeing a lot of other areas where people are kind of recognizing that this is something that's people are eligible for, that they can be claiming. We were just talking with Indiana and their ombudsman program, and they're really interested in drawing down MAC for that, and thinking that we should do a presentation with the national ombudsman program on that, because that's a key component that supports the Medicaid program. Most of that is typically state-only funds, and there's certainly not enough ombudsmen to cover all of the issues that you have in LTSS institutions for that. So we're seeing a lot of that. We are seeing a lot in terms of the brain injuries. The National Association of Brain Injury Administrators has been doing a fair amount on this and kind of picking it up on it. Easter Seals nationally has taken a big interest in this and kind of recognizing that this is a big opportunity. So you're seeing a lot of growth on this. And I don't think you showed did you have your slide in terms of the states?
No, we don't have a slide with the states now, but we are seeing interest in APS as well, Adult Protective Services. So that's another area that could really sort of match some of the work that you all are doing.
Yeah. Do you think about like in Anchorage? I know you guys have that great program where you're working with some of the police departments for people that have mental health issues, so that you can have somebody who's got a mental health background that's working with the police to responding to different types of interventions on that. I know that can be really helpful. That's something that that could potentially be claimable. Because in Alaska, you've got a lot of really innovative programs that you have going on both at the local level and regional and state levels for it, and many of those things potentially could be claimable.
To be a little bit more specific about the assistive technology, could MAC pay for the supports that people need in their home if a state does not already bill for those items?
That would be something that we would want to get clarification on. Probably not. I think that we're kind of like crossing the line too far. I don't know, Ami, if that's ever been posed to CMS as a question for it.
I mean, that's more of like a direct service. It's more equivalent to that, because you're paying for the equipment itself. That's not an administrative function, right? That's not the process of helping a person who might be eligible for Medicaid understand what technology they might be eligible for, might be useful for them. That process could be claimable, like that staff time talking to an individual about that potential, but not the actual item itself, not the cost of the technology.
Yeah, so Kelda, if you think about ATLA, which is the assistive technology, a nonprofit that helps people to locate the assistive technology, I would guess that a large portion of their staff time potentially could be claimable because they're going out and identifying people, training people on the use of the equipment and so forth. And for a lot of the assistive technology, that is some of the biggest cost components of it.
And you mentioned supporting social determinants of health. If someone is Medicaid eligible or in spend down, whatever the criteria are that are established for a state, would then housing navigation or childcare navigation, would those potentially be items that could be added?
That and you're helping that person to remain in the community and remain in the community independently. If we're making that case, then certainly that seems like something that potentially could be claimable. We'd want to look at the specific, but there's a lot of things that help that people need to kind of remain in the community independently. Now, if somebody was already on Medicaid, then we would want to look in terms of if that's part of the expectation of the Medicaid funded case manager to be doing that. So if they're on that, and that is part of that expectation for that service within that, then it could be claimable. If it's clearly made that it's not part of the expectation for it and somebody is on Medicaid for it, then it potentially could be claimable.
Now, I'm going to guess that this varies quite a lot state by state, but do agencies that are sign an agreement to receive Medicaid administrative claiming, do they need to be certified Medicaid providers? Are there particular requirements that they have to have in order to receive MAC?
No. No, they don't. And a lot of them are, most of the agencies that we're working with aren't direct Medicaid providers. Some of them are for that. So we're always careful to make sure that they're not double dipping on any of the coding. The first code that we start out with is directly reimbursed by another source to make sure that they're not doing any double dipping. But for most of them are not. Like Peggy's situation, she didn't bill Medicaid at all, and she is able to participate in MAC.
And then another state that we're working with, we're helping them explore an RFI for a no wrong door system. And as part of that, the biggest carrot is MAC. But they're also, as far as the requirements, they have to be able to provide information referral or case management or one of the other core pieces. And that's one of the requirements. And the other is to have some sort of state or local funding. Those are really the two big pieces that we want to make sure of it, but everything else, there's not a lot of constraint around that. We want to make sure that you're performing those activities and that you have sufficient match.
And Tina was asking, I'm sorry, go ahead.
Tina was asking, can the administrative claiming be used with the child and youth population? And that's something that absolutely, in Nebraska, what we've done, we even have a spend down criteria for the child and youth population. And so while income and assets are treated differently for children, we are able to have functional criteria that would indicate they're at risk of institutionalization. And so that has been something where we've been able to push the envelope further because traditionally that's been more focused on the adult population, but there's definitely the opportunity to take advantage for children too.
Yeah, and in Nebraska, this has been really helpful. The state does not have a case managed program targeted on families with medically fragile children. So Monroe Meyer was able to use this to leverage obtaining some foundation funds with that to start that kind of a program. So they now have that case management program that supports families of medically fragile children and helping them to remain in the community. So yeah, that is, it's Nebraska kind of pushed the envelope for it, but we did try to come up with then a criteria for considering them at risk on that was acceptable to the Medicaid agency and something that could be operationalized by Monroe Meyer, and it's worked really well for them. Actually, Hawaii is now planning to going down this route too, where they're looking at the child health family services branch and for a lot of their staff to add them to the Medicaid administrative planning, because it's a lot of the things that they do with state-only funds. Okay. Any other questions or comments? Okay. As I mentioned, the trust has been supporting us for quite a while. We're very grateful for all of the work that it allows us to do. If there are other discussions that you want to have and things you want to explore, if you send an email to Kelda, she will tell us if that fits within the contract, and then there's resources for us to be able to provide that support. Kelda, do you have anything you wanted to add before we close out?
I just wanted to thank HCBS Strategies, Nebraska State Unit on Aging, and the Administration for Community Living for all being available today. I really appreciate this opportunity. I think it's adds a lot to the knowledge base for Alaska and gives us a way to move forward with increasingly difficult budget times, and looking at how we can provide some of these administrative services in a little bit of a different way, or be able to expand to meet the great need out there. So thank you all very much. I really appreciate you being available today, and I learned a lot.
Great, great. Thanks to you all for listening, and we're going to go ahead and then close out the webinar.
Thank you.
Thank you.
Bye.